Welcome to the Deep Dive, where we sift through the latest research to bring you the insights that matter. Today, we're doing something a bit special. Deep Dive Ortho, focusing specifically on topics crucial for you as medical professionals in orthopedics. We're tackling something you see everywhere, don't you? From elite athletes to your own post-op patients, compression garments. They look simple enough, these bits of fabric, but they promise so much. Better performance, faster recovery, even stopping injuries before they happen. Almost sounds like a shortcut. But how much is solid science and how much is just, well, perception? For us in orthopedics, getting this right when advising patients is absolutely key, isn't it? And to help us navigate all this, we have Professor Mo Imam back with us, who's brilliant at translating complex research into practical advice. Welcome.
Thank you. It's good to be here. And yes, this is a really pertinent topic. Compression wear is, well, it's everywhere in sports and clinical practice, so it's absolutely vital. Our recommendations stem from solid evidence, not just, popular trends or what people happen to believe. So in this deep dive, we'll first unpack the basic science. How are these garments supposed to work? Then we'll really dig into the research. We'll look at specific studies, lower limbs in running, forearms in climbing, even other clinical areas. We'll cover performance, recovery, injury prevention, really trying to separate the proven benefits from the perceived ones. That's the mission today.
Excellent. Right then, let's start at the beginning. Before we get into the nitty-gritty of the studies, can you give us that foundational understanding? What are compression sleeves and how are they meant to work physiologically?
Certainly. Okay, so fundamentally, these aren't just tight clothes. They are specifically engineered garments, usually made from elasticated fabrics, nylon, spandex, polyester blends. The key difference is they apply a gentle but crucially graduated pressure.
Graduated, so not just tight all over.
Exactly. That's the critical part. The pressure is designed to be greatest furthest from the heart, say, around the ankle in a calf sleeve, and then it gradually lessens as you move up the limb towards the body. This specific design, this gradient, is fundamental to how they're thought to work.
Right, that makes sense. So it's a specific decreasing pressure. How does that actually help with circulation then?
Well, that leads us straight to the primary mechanism improving circulatory efficiency. This pressure gradient mainly affects the veins. Arteries have higher pressure, they're less compressible. But the veins, especially the superficial ones, are more easily influenced. The external pressure helps narrow these veins slightly. This increases the speed and pressure of the blood flowing back towards the heart, working against gravity.
Ah, so it gives the venous return a bit of a boost.
Precisely. And that has knock-on benefits. Better venous return also means better lymphatic outflow. The lymphatic system clears waste products and excess fluid from the tissues. So enhancing this drainage is thought to be key for recovery, clearing out metabolic byproducts, reducing swelling. Researchers often point to this enhanced venous and lymphatic flow as the main reason for the recovery benefits people report. It's all about improving that fluid exchange.
Okay, that circulatory aspect is clear, but you also hear a lot about compression reducing muscle vibration or oscillation. How does that work? Is that a separate thing?
Yes, it's another proposed mechanism. Think about high-impact activity like running.
Yeah.
With each foot strike, your muscles naturally vibrate or oscillate.
Like a wobble.
Exactly, a sort of jiggling or shaking. This repetitive oscillation can cause micro damage within the muscle fibers, contribute to fatigue, and potentially even increase injury risk by stressing connective tissues. So the idea with compression wear is that it acts like an external support, encasing the muscle snugly. This helps to dampen or reduce that vibration. By stabilizing the muscle, it potentially minimizes that microtrauma.
So less shaking means less damage and maybe less fatigue.
That's the theory. Less oscillation could mean less microscopic damage, delaying fatigue, helping preserve muscle function, and maybe lowering the cumulative stress that leads to injury. It's like giving the muscle a bit of external scaffolding, if you like, a concept we understand well in orthopedics.
That's a helpful way to think about it. So more than just feeling held. And I assume it's not just calf sleeves. There are different types for different body parts.
Oh, absolutely. Calf sleeves are very common, especially for runners, but the range is quite wide. You have arm sleeves, often used in climbing, which we'll discuss, or for managing things like lymphedema. There are full tights covering the whole lower body, quads, hamstrings, glutes. And then you have compression socks, sometimes for medical reasons like venous problems or for travel to prevent DVT. Each type is designed to apply that graduated pressure to a specific area, supporting different muscles depending on the activity or the clinical need. But the underlying principle remains the same.
Right, got it. Okay, let's move on to one of the biggest claims then. Performance. Athletes often wear them thinking it gives them an edge. What does the actual research say? Let's look at those studies, maybe start with trail running.
Yes, this is where the evidence gets, well, Interesting and often less clear-cut than people think. The Curve study from 2017 on trail running is a good place to start. Trail running puts huge stress on the lower limbs, doesn't it? It was a well-conducted study, randomized crossover, 14 trained male runners. The crossover design is strong because each person is their own control, which helps reduce variability.
So everyone did both conditions, with and without the sleeves.
Exactly. Two identical 24-kilometer trail runs a week apart. One run with proper digressive compression sleeves around 23 millipidal Hg pressure, which is a standard level. The other run with placebo sleeves, very low pressure, under 4 millimidal Hg. And they simulated real trail conditions, some flat running, some hilly technical sections, a really thorough setup.
Sounds like it. And what were they actually measuring to see if the sleeves made a difference? Just the finishing time?
Oh, no, much more than that. They looked at running time, of course, but
Yeah.
also heart rate, muscle oxygenation using NIRS on the calf muscle that gives you an idea of local blood flow and oxygen use.
NIRS, right. Non-invasive.
Yes. They also did functional tests, hopping tests before and after to assess muscle power and stiffness. And crucially for us, detailed biomechanical analysis. They looked at kinematics, vertical stiffness, leg stiffness while running at a set speed. So a really broad look at performance, physiology, and mechanics.
Okay, a very comprehensive study. So the big question, did the sleeves make them run faster or more efficiently? What did they find?
Well, the main headline, and it's in the study's title, was clear. No significant effect on performance or the core physiological measures. Average speed, VO2 max, heart rate, none, were significantly different whether they wore the compression sleeves or the placebo sleeves. This was true for both the flatter sections and the tougher, hilly terrain.
No difference at all. That does challenge the common idea, doesn't it?
It certainly does, for direct endurance performance in this context. But, and this is where it gets really quite interesting for us, whilst the overall performance metrics didn't change, they did find statistically significant changes in running biomechanics.
Ah, okay, so they weren't faster, but how they ran changed.
Precisely. Things like contact time on the ground, how long they were in the air, peak forces, these parameters shifted slightly when wearing the compression sleeves. It implies the sleeves altered their stride mechanics, perhaps how they absorbed impact, or maybe even muscle activation patterns.
So subtle changes in movement, even if the stopwatch didn't show it, what might that mean?
Well, that's the question, isn't it? From a pure performance view, maybe not much, but from an orthopedic or rehabilitation perspective, could these subtle mechanical shifts be useful? Could altering load absorption or stride pattern help manage stress on joints or tissues during recovery from injury, even if it doesn't make someone faster? It opens up different avenues for thinking about why someone might use them beyond just speed. It hints at modifying load, which is key in our field.
That's a fascinating angle. Not faster, but potentially running differently. Okay, let's switch focus from legs to arms. Sports climbing that puts incredible demands on the forearms. What did the Limmer study find about compression sleeves there?
Right, the Limmer study from 2022. Another randomized controlled crossover trial, this time with 24 experienced climbers. The logic was clear. Climbing involves intense, often intermittent, gripping. So they wanted to see if forearm compression sleeves had any immediate effect on finger flexor strength, endurance, and importantly, the local hemodynamics, the blood flow and oxygenation in those forearm muscles.
Makes sense. What specific climbing things did they measure?
They used a range of tests relevant to climbing. Intermittent hand grip strength, measuring peak force and how quickly strength dropped off, the fatigue index. Also finger hang time, how long they could hang from a small edge. And they measured actual climbing performance, lap climbing distance and time. Plus, they checked blood lactate levels, perceived exertion, RPE, and muscle pain. A really thorough climbing-specific assessment.
Okay, so they covered strength, endurance, and actual climbing. What was the verdict on performance? Did the sleeves help?
Again, a very clear finding. No significant effect on any of the performance measures. Grip strength, endurance, hang time, climbing distance, lactate, RPE, pain, none were improved when wearing the compression sleeves compared to the control conditions.
None at all. That's pretty definitive for climbing performance then.
It appears so for these immediate effects. They did note, as you'd expect, that men generally had higher grip strength than women, but their actual climbing ability levels were similar across the sexes in the group. But the sleeves themselves offered no measurable performance advantage.
Okay, similar story to the running study on the performance front. But you mentioned they also looked at hemodynamics using NIRS, like the running study did. Did they see anything there? Any sign of that improved circulation theory?
Yes, and this is where it gets intriguing again, mirroring the complexity we saw in the running study. Despite no performance benefits, they did find significant effects on the NIRS measurements during the intermittent gripping tasks.
Intermittent gripping specifically.
Yes, during the repetitive grip strength and endurance tests, they saw greater changes in oxygenated hemoglobin and tissue oxygen saturation, SDO2, when the climbers wore the compression sleeves. This suggests that during those cycles of muscle contraction and relaxation, the sleeves were indeed influencing local blood flow and oxygen delivery to the muscle tissue.
So a physiological effect was happening.
It seems so, specifically during that type of intermittent activity. However, two crucial caveats. First, these hemodynamic changes were not seen during sustained, continuous contractions like the finger hang test. And second, the researchers concluded that although these changes were statistically significant, they were quantitatively quite small, only about a 3% change in tissue saturation.
Only 3%, so measurable, but perhaps not enough to make a real difference.
Exactly. Their conclusion was that these subtle hemodynamic shifts were likely too small to translate into any meaningful performance benefit. It reinforces their caution that claims of performance benefits should be viewed very carefully. There's a physiological flicker, perhaps, but not enough to power better performance.
Right. So across both running and climbing, the picture seems to be maybe some subtle physiological or biomechanical effects, but little to no direct significant impact on actual performance outcomes like speed or strength. Is that a fair summary?
I think that's a very fair summary of the evidence we've discussed and what broader reviews often suggest. Some meta-analyses might hint at very slight improvements in things like running economy under specific conditions, but it's often marginal. Other studies find absolutely no effect, especially in high-intensity activities. So the idea that compression wear is a reliable performance booster across the board just isn't strongly supported by the current science. Any effects seem to be minor, context-dependent, and perhaps not what most users expect. We need to be nuanced.
Definitely. Okay, let's shift gears then. Beyond performance, what about recovery and injury prevention? These are huge selling points. How strong is the evidence here, particularly from our orthopedic viewpoint?
This is a really critical area because the perception of benefit here is extremely strong, both among athletes and, frankly, some clinicians too. Let's start with post-exercise recovery. The theory makes good physiological sense, linking back to that improved circulation and lymphatic drainage we discussed. The idea is that better flow helps clear out metabolic waste, things like lactate and markers of muscle damage like creatine kinase, CK, more quickly.
And faster clearance should mean faster recovery, less soreness.
That's the rationale. And several good meta-analyses, like those by Hill and Engel cited in the Franke paper, do support this. They show that using compression garments consistently can lead to a noticeable reduction in delayed onset muscle soreness DOMS, that post-exercise ache we all know. They also suggest it can delay the onset of fatigue in subsequent exercise sessions, so it points towards a more effective recovery process.
So for recovery, the evidence seems more positive.
Yes. The evidence for recovery benefits is generally considered more robust than for direct performance enhancement. That Franke study, the large survey, found over 80% of athletes felt they recovered faster using compression. For our orthopedic patients, perhaps post-surgery or post-injury, managing swelling, reducing that muscle soreness, potentially clearing inflammatory markers faster. These could be genuinely helpful aspects for improving comfort and maybe facilitating rehab progression.
And the advice then would be to wear them.
Based on the research looking at DOMS and fatigue markers, wearing them both during and immediately after the exercise or rehab session seems to offer the most consistent benefits for recovery rather than just putting them on afterwards.
Okay, recovery looks promising, but what about the holy grail injury prevention? You mentioned the perception is strong, but what's the hard evidence? Can these garments actually stop injuries happening?
This is where we see a significant gap between that strong user perception and the definitive scientific proof. That Franke survey was revealing. Nearly half the athletes use them mainly to prevent re-injury, secondary prevention. About 15% use them to manage a current injury, most commonly shin or calf problems. And as we said, over 80% believe the garments help them prevent injuries.
Huge belief. But what did the study conclude about actual prevention?
Well, it found an association. Runners who consistently used compression socks or tubes reported fewer lower limb injuries. But, and this is the crucial bit, it was a cross-sectional study. It shows a link, but it absolutely cannot prove cause and effect.
So we can't say the socks prevented the injury.
Exactly. Maybe the runners who chose to wear compression were also more careful about training load or did better warm-ups, or were just different in other ways that reduced their injury risk. The study itself highlights this major gap. We lack robust, prospective studies definitively proving that compression garments directly prevent primary or even recurrent sports injuries.
So why the strong belief then, if the direct proof isn't quite there, placebo? Or something subtle we're missing?
It could be a combination of factors. Placebo effects in sport are powerful, undoubtedly. Feeling supported might make an athlete feel more confident or less vulnerable. But there might be subtle mechanisms, too. Could the improved proprioception? Some studies hint at that better sense of limb position help avoid awkward movements? Perhaps. Could reducing muscle fatigue slightly delay the point where technique breaks down, indirectly lowering risk? Maybe. These are plausible ideas, but they need more rigorous investigation. The bottom line for now is we can't confidently tell patients that wearing these will prevent injury as a standalone measure. They aren't a substitute for proven prevention strategies.
Right. So if compression isn't the proven fix for prevention, what does work? What should we be emphasizing based on solid evidence, especially for younger athletes who are still developing?
Absolutely. We need to focus on the fundamentals where the evidence is strong. That Abernethy and Bleakley's systematic review on adolescent sport injuries is really key here. It confirmed sport is the main cause of injury for adolescents, so prevention is vital. And the strategies with consistent evidence are things like proper preseason conditioning, functional training that mimics the sport, educating athletes on technique and risks, balance training, and refining sport-specific skills throughout the season.
So it's about building a more resilient athlete through training, not just relying on gear.
Precisely. It's about improving strength, neuromuscular control, stability. The functional components are crucial. Contrast that with other protective gear. The review found limited or inconclusive evidence for things like eye goggles or knee pads in many situations. And importantly, no positive effect for general headgear in preventing concussion in many sports, or for knee braces in preventing knee injuries in athletes without existing instability.
No effect from knee braces. I thought they were supposed to protect the knee.
Well, the evidence for prevention in uninjured knees is weak. And even more concerning, some studies suggested knee braces might actually increase the risk of injury elsewhere, particularly to the ankle and foot on the same side.
Increase the risk. Why would that happen?
Several possibilities. Study design flaws could play a role, but biomechanically, a brace might alter natural movement patterns, potentially reduce proprioceptive feedback, or even lead to muscle fatigue and compensating muscles, paradoxically increasing overall risk. It highlights that external supports can have complex, sometimes unintended consequences.
That's quite counterintuitive. What about something seemingly basic like stretching? We always tell people to stretch. Does that prevent injuries?
Again, perhaps counterintuitively, the evidence is surprisingly weak. The same review pointed out that static stretching alone, or even as part of a standard warm-up cool-down, often doesn't significantly reduce injury risk in many groups. Think Army recruits, footballers, runners.
Really? So all that holding stretches?
It might improve flexibility, which is important for some sports, but it doesn't seem to be a major factor in preventing most acute or overuse injuries. The focus seems to be shifting more towards dynamic warm-ups, activating the muscles you're about to use, rather than passive stretching.
Fascinating. Okay, so if generic approaches like stretching or simple braces aren't the answer, what about more tailored programs, like arm care for throwing athletes?
Yes, arm care programs, like those McElhenney described, are a great example of a holistic, evidence-informed approach, particularly for throwing sports like baseball, where the forces are immense and repetitive. These aren't just about the arm. They address the entire kinetic chain. They include specific flexibility work, strengthening for the rotator cuff, scapula stabilizers, the core, plus proprioceptive training to improve control and body awareness.
The whole system working together.
Exactly.
Yep.
Proper warm-ups, cool-downs, progressing exercises. Logically, it's a comprehensive strategy targeting the known risk factors for throwing injuries. Far more effective than just, say, wearing an elbow sleeve.
Makes sense. And what about really common things like ankle sprains? We see those all the time. Does taping or bracing help there?
Ankle sprains are incredibly common, mostly lateral ligament sprains. Taping can definitely help, especially acutely. It provides mechanical support, restricts excessive movement, particularly before exercise. But that mechanical support tends to wear off quite quickly with activity, maybe after 40 minutes or so.
So the tape loosens.
Yes. But perhaps the most important benefit of taping, especially for ankles that have been sprained before and feel unstable, is improving proprioception.
Ah, that sense of joint position again.
Right. The tape provides feedback, enhances the brain's awareness of where the ankle is, potentially allowing for quicker muscle reactions to prevent rolling it again. This benefit seems strongest before exercise. The effects after exercise are a bit more complex and less consistent in studies. So, great for immediate pre-activity support or as part of rehab for instability.
Okay. And finally, conditions like tendinitis. How does compression fit into managing those common overuse issues?
Tendinitis, the inflammation causing pain, stiffness, maybe a grating feeling, very common. For mild, acute cases, compression is a standard part of RICE. Rest, ice, compression, elevation. Using an elastic bandage or a soft brace helps reduce swelling and provides some support to the irritated tendon, aiming to ease pain. Snug, not tight, and definitely off at night.
Standard first aid, essentially.
Yes, but if symptoms persist or are severe, they need proper assessment by a GP, physio, or orthopedic specialist, of course. Persistent tendon issues need careful management. And preventing tendinitis in the first place comes back to those core principles. Proper warm-up, good technique, avoiding sudden load increases, managing repetitive movements, using the right gear. Compression helps manage the flare-up, but prevention is about addressing the underlying causes.
Brilliant overview. Thank you. So let's bring this all together for the clinicians listening. If we're advising patients or athletes, how do we translate all this complex information into practical, evidence-based advice on compression wear and injury prevention?
Right, the practical application. When recommending compression wear, if we choose to do so, 3 things are key: fit, material, and the compression level. The fit needs to be snug to apply that gradient correctly, but absolutely not restrictive. Material should be breathable, moisture wicking for comfort, and the compression level needs to suit the purpose, maybe 10-15 mmHg for general recovery or travel, perhaps 20-30 mmHg for more active use or specific venous issues.
And managing expectations is important too, you mentioned.
Hugely important. We need to be clear that the look good factor, while maybe a psychological plus for some, isn't a clinical reason to recommend them. Our advice has to be grounded in potential efficacy.
So when should we consider recommending them? What are the evidence-backed scenarios?
Okay, based on our discussion. During exercise, possibly for that perceived reduction in muscle vibration and fatigue, and maybe for those subtle biomechanical shifts the Curvey study hinted at. Not for speed, but perhaps for influencing load or comfort in certain individuals. Post-exercise or post-injury. This is where the evidence is strongest. Definitely consider recommending them for enhancing recovery, reducing DOMS, helping clear metabolic byproducts. For our orthopedic patients, this could mean less swelling, more comfort during rehab. And remember, wearing them during and after seems best for recovery. During sedentary period-specific conditions, yes, for long travel to prevent DVT, or for patients with known venous insufficiency or edema issues. That's a clear clinical application.
That clarifies the when, but we also need to be upfront about the research gaps, especially around injury prevention, don't we? How do we handle that conversation?
Absolutely. Transparency is key. We need to honestly state that robust evidence proving compression garments directly prevent injuries is still lacking, despite what many people believe or perceive. We can mention it's an area of ongoing research. Studies are looking into their effects in various settings, maybe post-surgically, perhaps even contexts like robotic surgery, although specific results might still be pending. It shows the science is still evolving. But we must stress that compression is not the primary preventative strategy.
So it's about putting compression in its place as one tool among many.
Exactly. It's one tool in a much larger toolkit. It is not a magic bullet for performance or injury prevention. We must keep reinforcing the importance of the fundamentals. Proper conditioning, functional training, warm-ups, cool-downs, technique work, proprioceptive exercises. These are the cornerstones of building resilience. Our role is to guide patients and athletes, manage their expectations realistically, help them understand the difference between feeling better perhaps and having a scientifically proven performance or preventative effect. It's about holistic, evidence-informed care.
That's a really clear and responsible approach. It beautifully summarizes the nuances we've explored today. We've seen how compression aims to work physiologically, its stronger role in recovery compared to direct performance, and the important distinction between perception and proof when it comes to injury prevention. If you've found this deep dive valuable for your practice, please do consider rating and sharing it with colleagues. It really does help us continue bringing these evidence-based discussions to you.
And perhaps a final thought for you. Listening as an orthopedic professional, Knowing about these subtle biomechanical and physiological effects, even if they don't always boost performance, how might this deeper understanding shape the way you educate patients, design rehabilitation programs, and think about long-term musculoskeletal health?
A very pertinent question to reflect on. Professor Moimam, thank you so much for sharing your expertise and guiding us through this complex topic today. And thank you all for joining us on Deep Dive Ortho. We look forward to exploring more vital topics with you next time.